Well, welcome everyone to the transvenous pacer module. The purpose of this module is to review the insertion of a transvenous pacer. Seems kind of obvious. And we're going to actually go over the insertion both of the cordis as well as the steps to float the pacemaker. These have some subtle variations, both in the insertion of the cordis and of course the team effort that's required to float the pacemaker. So good for all parties to review. Sit back, relax, and enjoy our module. So to begin with, notice that we use a slightly different cordis set. In this case, this is a 6 French cordis specific for pacing, and it's quite obvious because it is actually labeled in green. So different than the blue cordis set that we would normally place in the emergency department or with other patients. To begin the procedure, the physician will be donning their sterile cap, gown, gloves, and mask, and during this time you can open the cordis kit up, maintaining sterile technique. Next, go ahead and place the 3 skin sterilizing swabs on the tray. And go ahead and add a 10 cc saline flush and an IV cap to your tray for flushing the line afterwards. And at this point you can rearrange the sterile dressings and drapes on your kit, revealing the remainder of your kit. So for your next step, you should assemble the cordis and dilator. Note that the dilator and cordis do not come pre-assembled, and you actually have to put the dilator through the introducer end of the cordis prior to use, as demonstrated here. Similarly, go ahead and set up your guide wire by removing the cap. Also, utilizing your thumb, go ahead and advance the guide wire slightly, as it is a little sticky as it is moved for the first time. So at this point, go ahead and position your patient with the head down in Trendelenburg and slightly turned to the left. Proceed then to sterilize the skin with your sterilizing swabs, working from the center of your insertion site outwards. Do this 3 times. Once sterilized, go ahead and place the large procedure drape on the patient. Note that this drape comes with our transvenous pacer kit and is quite extensive to maintain a large sterile field. Using a procedure that is identical to our usual ultrasound-guided central line placement, go ahead and use the steel needle in order to puncture and aspirate free-flowing blood from the right internal jugular vein. At this point, go ahead and remove the syringe from your introducer needle, all the while steadying the needle with your opposite hand. Then proceed to thread your guide wire down the introducer needle and into the right internal jugular vein. The guide wire should proceed with very minimal resistance. It's important to note not to force the guide wire at all. Once the guide wire has easily entered the vein, go ahead and steady the guide wire, and in the same motion you may remove the introducer needle over the guide wire, all the while maintaining one-handed grip on the guide wire. At this point, utilize your scalpel to make a skin incision directly over the wire and into the skin. This incision will allow your dilator and cordis to enter the neck freely. So now go ahead and advance your dilator and cordis over your guide wire, all the time maintaining control of your guide wire. Note that as you advance, the dilator will want to push backwards out of the cordis, so secure this with your thumb and advance it all as one unit. The dilator and cordis should advance easily into the skin and into the right IJ. The resistance that you've seen on this video is simply due to the mannequin. At this point, go ahead and remove the dilator and the wire. Note you can remove them separately or all as one unit. Now go ahead and bleed back the air out of your line. Follow this up by flushing with the 10 cc's of normal saline. Note in this case we have applied the IV cap to the flush, saving ourselves an extra step. And finally, go ahead and suture your line in place. Note that we did not demonstrate the entire suturing procedure here. Once the line is sutured in place, we are now ready to float the pacemaker. We can begin by opening up the pacemaker wire. Open this up and present it sterilely to the physician doing the procedure. And now with sterile technique, go ahead and open the pacer wire kit. So at this point, you can remove the pacer wire from its case under sterile technique. Also, go ahead and remove the syringe for inflation of the balloon. And prior to handing it over to the AMC, the physician will often attach the syringe. Once connected, this end will be handed off to the AMC for use. On the next step, the sheath is now placed over the pacing wire. Note that this sheath must have the blue connecting end closest to the balloon end of the pacing wire. Failure to do so will cause significant troubles down the road. At this point, we are ready to test the balloon's integrity. The physician will ask for balloon up. Open the stopcock and inflate with air, verifying that the balloon is intact and inflates. Let the air out and you're done. So at this point, go ahead and attach your leads to the pacemaker. Remember the P's, so the proximal lead goes to the positive end, and thus the distal lead will go to the negative end. You can't quite see that here on this video. Ensure that as you insert the leads, they are tightened in fully, and at the end, give them a small check to ensure they are not loose. And this may seem obvious, but ensure that your pacemaker leads are actually connected to your pacer box. And at this point, ensure that you have batteries in the pacer box. And go ahead and turn the pacer box on. As per the procedure card, use the down arrow button to scroll down to VVI and then press enter to set it to VVI pacing mode. Now go ahead and set your rate. It should usually be 20 or 30 above the patient's baseline rate. In this case, we're going to set it upwards to 90. And go ahead and set your current to maximum. And finally, go ahead and set your sensitivity all the way up to 1 or most sensitive. At this point, the physician will retract the sheath back to approximately 30 centimeters, and then we'll begin to insert the pacemaker wire. Note that the pacemaker wire must first be inserted at least 12 to 14 centimeters so the balloon does not inflate inside the cordis. At this point, the physician will request balloon up, ensure the stopcock is open, and inflate the balloon. At this point, the physician will advance the pacer wire, all the while watching the cardiac monitor for signs of electrical capture. Electrical capture will be noted on the monitor when the underlying rhythm suddenly transforms to a wide, complex beats that occur at the paced frequency. At this point, palpate your patient's central pulse and ensure you have mechanical capture. Following this, the physician will ask you to go balloon down and ensure that you still have mechanical and electrical capture. Once this has been obtained, you will begin to dial back the pacing current until you lose capture, and then proceed to re-establish capture and increase the voltage by approximately 20% as per guidelines. Once capture is confirmed, go ahead and attach the sheath onto the locking portion of the cordis and extend the sheath backwards over top of the pacer wire so that it can be adjusted in a sterile manner if need be. Then go ahead and secure the sheath to the pacer wire using the op site provided. As the procedure is now complete, feel free to remove the drape from your patient. Now go ahead and place the provided op site onto the cordis site. Note that the cordis itself can be held down with the dressing, but the pacer wire itself should be free as seen here. And finally, utilize the sandwich technique to secure the pacer wire to your patient. In this case, the pacer wire is sandwiched between two sets of 4x4s, which are then taped to your patient, ensuring that the wire itself is never taped to the patient and thus not able to be pulled.